Assalamualaikum and good day. I'm your Amlizan Ramli, Associate Professor from Department of Pharmaceutical Technology, Faculty of Pharmacy, University Technology Mara, Malaysia. Thank you for the kind invitation for this prestigious third International Brain and Biomedicines Conferences 2026. Today, I will share with you a bit of research work that we have done in the faculty with my research group, which is Beyond the Skin, Rethinking Therapeutics Through the Patient Experience. Let me start with this contrast. On the left, this is how we describe the disease: immune response, barrier dysfunction, molecular pathways. But on the right, this is what patients actually live with. Patients with atopic dermatitis always experience persistent itch, sleep disruption, visible lesion, and also social discomfort, especially if the disease occurred at the exposed area. And this is where the gap exists. We are very good at describing the disease. We understand up to the cellular level, but we sometimes overlook the experience of the patient. This slide shows the full pathogenesis cycle of atopic dermatitis. It starts with barrier dysfunction, which leads to immune activation, which later triggers inflammation, and then itchiness occur. And that itch leads to patient to scratch, which further damages the barrier, which is the skin. So this becomes a vicious cycle. And importantly, the cycle is not just biological. It directly translates into what the patient feels every single day. When we look at current treatment options, we see clear trade-offs. High efficacy often comes with side effects. Systemic treatments increase risk. Topicals may not repair the barrier effectively. And conventional crisaborole, while promising, still faces limitations. So what we are aiming for this study is the last column: high localized efficacy, minimal systemic exposure, and active barrier repair. This is really the turning point of our work. Biochemically, crisaborole is effective. It suppresses inflammatory cytokines, but clinically, it needs to remain in the skin layers for it to work. And here is the problem. Crisaborole has poor solubility, poor penetration, and rapid systemic inactivation. So I think we sort of understand here. The issue is not the effectiveness or efficiency of the drug. The issue is how we deliver it. We may have the right molecule, but the delivery is wrong. This is the mechanism of crisaborole. I'll keep it simple, I promise. Crisaborole inhibits PDE4, which increases intracellular cAMP, and that suppresses inflammatory cytokines. So mechanistically, everything works, but again, it only works if the drug reaches the right place. Our approach is not to reinvent the drug. It is to redesign how it is being delivered. Therefore, we develop a nanoemulsion system where the drug, crisaborole, is stabilized, protected, and guided into the skin layers. So the focus shifts from molecule to delivery. So we have crisaborole and vitamin E as a core. We have PEG40 as a shell for stabilizing effects. And also we have the matrix, which is sodium carboxymethyl cellulose, as a hydrator. This is part of the formulation optimization. We compared PEG40 and PEG35. PEG40 gave us better particle size control, better uniformity, and stronger stability. So it was selected as the primary surfactant. This step is critical because stability determines whether the system that we want to have works consistently throughout. This is what I call the Goldilocks zone. Not too large, not too small, but just right for optimal penetration. So out of many formulations that we have worked with, our formulation 14 sits here with ideal particle size, good uniformity, and stable zeta potential. This is where performance starts to become predictable. Highlight something often overlooked, which is the user experience. The formulation must glide smoothly, retain the drug in place, as well as maintain hydration. As we all know, atopic dermatitis means excessive dryness of the skin. So maintenance of hydration is very, very important for AD patient. So sodium carboxymethyl cellulose matrix helps create the balance: application, retention, and hydration, all these three. So now we are not just designing for delivery, but we are also designing for use. I always use this term when I explain this system. It actually works as 3-in-1. It works to deliver the drug, maintain the hydration, as well as it has the antioxidant capacity of the vitamin E that we used.
This is the ex vivo permeation model. What we observed is significantly higher local accumulation compared to conventional formulations. And importantly, the drug is retained where inflammation occurs instead of being washed away into systemic circulation. As I mentioned much earlier, crisaborole, when it is washed away into the systemic circulation, it loses its activity. So we are achieving targeted delivery. This is where it becomes interesting. The nanoemulsion creates a reservoir in the stratum corneum. So instead of a quick burst and loss, we get sustained release. High penetration in the epidermis, minimal escape systemically, so the drug stays where the disease is. We also run in vivo model where we, for validation of course, because what we did was we induced dermatitis on the NFB mouse model. We applied treatment over several days and compared outcomes. So this allows us to move from theory to actual biological response. This is the visible outcome. The untreated group shows persistent inflammation, and the standard treatment shows partial recovery. But the nanoemulsion shows complete re-epithelialization. So this is not subtle, it is clearly observable.
And when we go deeper, this is what we see microscopically: reduced inflammatory cells, restored collagen structure, successful re-epithelialization. So we are not just treating the surface, we are not just maintaining the drug at its place where it will work effectively, but we are also repairing at the tissue level.
When we compare directly, we see better penetration, better retention, better comfort, and also faster healing. And this combination is important because patients don't just need efficacy, they need usability.
This system works because of these three components: the drugs, crisaborole, which suppresses inflammation, the carrier, which enhances penetration, and the matrix, which maintains hydration. So together, they create a microenvironment for healing for atopic dermatitis. So healing is not from the drug alone, but from the whole system of the nanoemulsion. This approach also opens up broader application. We can reduce systemic toxicity, deliver difficult drugs more effectively, and design formulations that patients are more willing to use. So this is not limited to one condition, it is actually a platform. We can actually utilize this system for other model drugs as well. And finally, as a conclusion, This is what it means for the patient: less age, better sleep, improved daily functioning. And this is where everything comes together. See, because we at the bench side, we often measure outcomes in numbers, but patients experience outcomes in daily life. So the real questions is not just does it work, but does it improve the patient's life? If atopic dermatitis patient or eczematous patient who flares up, the eczema flares up, and they still cannot sleep, the treatment has not fully worked. So I would like to introduce to our faculties as Faculty of Pharmacy. The building down there is basically our 5 blocks faculty. We have huge numbers of classrooms, laboratory, animal house, rooms for lecturers, computer labs, and we are located at UiTM Puncak Alam campus. And the gentleman with me there is Dr. Muhammad Hafiz Muhammad Jaafar. He is a PhD graduate who actually did this project.
I would like to thank the organising committee again and Dr. Said Harun for the invitation. Really appreciate this opportunity to share our work in UiTM. I wish you all a fruitful and productive conference session ahead. Have a nice day and thank you. Be kind to your mind and don't forget to smile.